food we have left and encourage you to eat it. If you're a grad student that came here today without any Ziploc or produce bags, this is a learning moment. So start, collaborating with the archaeologists. They're very good at material culture about how to take it home with you. Otherwise, it's just going in the lounge. It's going to be eaten and drunk by people who are not you. It's very sad. This is basically a very, very brief run-through of my dissertation project. So the project itself is called Choosing Methadone, Managing Addiction and the Body Politic in Ukraine. This project was funded by a whole bunch of people, and I'm very grateful to them for doing that. Basically, what I have been researching, essentially since 2007, is the treatment trajectory of heroin addicts, opiate addicts, and drug users through different sort of standardized forms of drug treatment in Eastern Europe, particularly in Ukraine. So before we get too much further, I want to ask, does anyone here actually know what harm reduction is? Can anyone hazard a definition of harm reduction? Bettina's cheating. Yeah? What?
I've heard it, but I don't remember what it was. It wasn't something that I thought it was. It wasn't.
Okay. Anyone else? Hillary?
Helping to make practices you know are going to happen be done in a more healthful manner. Somehow.
Right. So there's a thing that people are going to do. How do we make it hurt them less? Right? And from a medical perspective, basically everything we do is harm reduction. Like, hey, let's do your appendectomy in an operating theater and not on my porch. Right? But harm reduction also is this interesting sort of social construct in that we tend to apply it to things that are considered sort of morally things that we don't really like, so like drug addiction or female circumcision or abortion or things like that. So it's this an approach that sees a decision to participate in behavior, like using injection drugs, as a series of choices along a spectrum. And there are more dangerous choices, and there are safer choices. And we are going to try to do things, provide material incentives, provide information to get you to try to make a safer choice. To that end, it's also sort of a moral stance in a way. This is a nice little piece of messaging from the Harm Reduction Alliance in New York that, it kind of sees, for example, drug use as a choice that people might have a fair right to make, the same way that I would go home on Friday and have a martini. Someone else might choose to manage their cells, their bodies, their stresses in some other way. Harm reduction tends to be a technological intervention. So, for example, condoms are a harm reduction technology. It's something that we have applied externally to a human behavior to try to reduce harms associated with that human behavior. And like any other sort of technological intervention, it's important to think about how people, from a social standpoint, interact with that technology. So I made a comment earlier this morning that in the lab, condoms are close to 100% effective at doing what they're supposed to do, and in real life, when it comes to people living in the real world, condoms are only about 70-80% effective at preventing pregnancy, preventing STIs, and that has to do with limited choice, that has to do with interpersonal violence, it has to do with us as a species just kind of not being able to do stuff well on a regular basis. There's a lot of user error that gets involved and drops that number down. So similarly, a lot of approaches to harm reduction with respect to drug use are technological interventions. So the idea is diabetics inject themselves every day with stuff. We do blood draws every day with needles. The technology, the actual syringe, shouldn't be what is spreading disease, so we're going to try to provide you with enough technology, things like free needles, things like sterile cookers, all those kind of materials, so that you don't have to do that. Substitution therapy. Anyone know what that is? Bettina's still cheating. Okay, who else? Jen.
Would that be like methadone instead of smack?
Yes, it would be like methadone instead of smack. So a very cheap and dirty way to define it is it's sort of like the patch, but for opiates. So there's a whole host of drugs. In the United States, they fall under a bunch of different schedules. I'm not going to go into it here, but if you don't know what a drug schedule is, go into that rabbit hole on Google after we leave here today. It's very, very interesting. But there's a few drugs that are pretty common. Methadone is one of the most common ones. There's something called LAM that's a little less popular. And buprenorphine that was developed more recently as a sort of, to be perfectly honest, white person's methadone. And these two drugs specifically, methadone and buprenorphine, are the one that's available in Ukraine. So the way it works is there's a daily supplied dose of this particular medication that's given to you. In the Ukrainian context, you have to go to the clinic and ingest this under medical supervision every single day, so you're not allowed to take it home by prescription. technically in some places you are, but that's a whole other conversation. So it kind of ties you to the clinic in a way, but it also provides you with a medically sound, standardized, structured, and most importantly, reliable source of the thing that you are addicted to, and that's considered a tool in the greater process of managing your addiction. So, this is one of the places where I did research. I just want to give you a little bit of a sense of kind of where I was and where I was poking around. This is the front gate into one of the large tuberculosis clinic treatment territories in Odessa, Ukraine. It's a city kind of in the south. If anyone's following the news, it's where there was that horrific fire a couple weeks ago. The grounds itself are very open and beautiful. Tuberculosis hospitals in Ukraine are kind of pretty places if you're not a patient there. This was actually the main doctor's office. This is the primary psychologist who ran the substitution therapy clinic in this hospital. She has excellent boots, and there are about 10 feral cats that live in her office, so this was snack time. It was just a really delightful place to be. And this is actually one of the many people that I interviewed. So I don't have too many pictures of people that I work with because I do not have IRB permission to photograph the people that I work with, understandably. But I thought that this was a really interesting picture because it indicates a number of ways in which these people are marked, both biologically and socially. So he has a healed abscess on his arm, but also carries this button in English in a Ukrainian and Russian-speaking part of the world that I thought was interesting. He can't actually read the button himself, but he knows what it says. It says, I'm sorry?
I was going to say, neither can we for the red
Yeah,
words.
so it says fight HIV and hepatitis C virus, not people using drugs. Okay? So even in the Ukrainian context, a lot of the same sort of philosophical approaches to harm reduction carry through, and people see it as medical care as a human right and things of that nature. So it's an interesting place to kind of ask these questions. So the reason why looking at the HIV epidemic and harm reduction in general in Ukraine is interesting, well, there's a lot of ways to look at it. So we tend to look at it in terms of epidemiological trends like this most often. So you can talk about how frequent infection is within the population. Currently they have a population prevalence of about 1.5%, which compared to certain places like South Africa doesn't seem terribly high, but for a country in Europe that's astonishingly high. It's one of the few places in the world where the HIV epidemic is still growing. Eastern Europe and Central Asia, it's still taking off. Other parts of the world, even though the total number of patients and people actually living with HIV is very, very high, the number of new infections is starting to be contained. Starting being a key word, right? Still a lot of work to do, but it's starting to be contained by a lot of the prevention and treatment work that's being done. Here, this is also unique because IV drug use has been one of the driving factors behind it. So frequently we have either heterosexual sex, same-sex sexual intercourse, or vertical transmission between mother and child being the primary factors driving the epidemic. Only a couple years ago, heterosexual intercourse overtook IV drug use as the primary mode of transmission for HIV in Ukraine. That's pretty interesting. It's probably as a result of a lot of programs like this, but the fact that IV drug use is a major driver is really significant. And there are certain epidemiological studies where you can actually go and see that people working in Odessa or people working in Mykolaiv could not find an HIV-negative drug user in their sample. Right? So some of the urban rates among IV drug users are as high. Puberty a couple of years ago was like 89%, something like that, and population-wide throughout the country, the HIV rate among IV drug users is considered to be about 20-25%. It's very, very high. On a practical level, it looks like this. So this is a very, very cool technology that I didn't even realize was diffusing into Ukraine until earlier this summer. So this is a 5-way blood test. Okay? I don't know if it's kind of hard to read. This one is blank, but this one tests for hepatitis B, hepatitis C, HIV, and syphilis. And this was just, I spent a lot of time actually in Lviv in Western Ukraine shadowing people who did an outreach van. They did a mobile clinic where they would distribute condoms, distribute needles, do blood tests. And this is just informational. This is not considered a diagnosis. Like if you get a double line here, then you should go to a doctor and you should do a blood draw and a proper Western blot and actually get diagnosed. But it was really common to see people with multiple co-infections, right? TB and HIV co-infection is really, really high in Ukraine. This person has hepatitis C, HIV, and syphilis. Syphilis tends to appear within social groups. Hepatitis C, everyone tends to have that. HIV, a few people do. So on a day-to-day basis, this is something that nurses running these clinics are seeing all the time. And that's sort of the local breakdown of why this is important. So I was studying opiate substitution therapy or methadone therapy as a diversion program for people who are living with, all right? Oh, okay, well then I'll talk faster. So people who are living with HIV and with addiction on a regular daily basis. the reason why this is important to know is because if you are the Global Fund, for example, and you are the person running all of the substitution therapy programs in Ukraine for HIV prevention purposes, if you want to improve those programs, if you want to scale up those programs and everything with them, you have to understand why people are interacting with them in the first place. And we have a whole bunch of models that explain treatment-seeking behaviors, right? And I'm going to run through a few of them really briefly just to kind of point out that they're all kind of crappy. They're all kind of equally crappy, the way that we think about these things. So this is the health belief model, where you think about, like, oh, what's the benefits, what's the risk? There's one that is called the theory of planned behavior, where you talk about norms and your demographic variables and things like that. There's another one called the healthcare utilization model that talks about predisposing factors, enabling factors. They're all pretty rough ways of looking at it. These are two of specifically psychological healthcare seeking, and I wanted to point this out just to show that a lot of them have things in common. So the recognition of a problem, activating your network, consulting a specialist, and then at the end, hopefully, resolving that problem. And I mention this just to say that this is how most people in a clinical setting on a daily basis are thinking about what their clients are doing in these particular settings. You have a problem that emerges, for example, a cavity has emerged in my tooth. Then that problem is recognized. Ow, I cannot eat my pizza without severe and intense pain. So you have to seek professional help for that problem. I shall go to the dentist and have my caries filled, and at the end the problem should be solved now that you have sought professional help for that problem. And in the midst of that, all of these things are mitigated by different systems of self-care. Like, have I used Oragel? Have I chosen to chew on the right side of my mouth for the last 3 weeks? You know, all these sort of different things that you do to manage what's going on throughout that entire time. So first, the problem emerges, and this is the way it kind of looks to both patients and physicians in this particular context. So the drug use problem in Ukraine is very interesting. People are injecting all kinds of things that I have never seen anyone inject before. I have a long history of working in harm reduction and needle exchange in the United States. Crocodile is something that has been very sensationalized in the news lately. That's something that people are injecting. It's basically they're taking these sort of things. These are cough drops that have codeine in them, grinding them up, passing them through a bunch of solutions, and then the goal is to be able to pour off a aqueous codeine solution at the top. Turns out that people in withdrawal are very bad chemists. So all kinds of things are being poured off and injected into bodies, and so that's a problematic thing. People tend to not use heroin. People tend to use shirka. So poppy seed, just the kind of thing that you'll get in a Spice Island jar for $6 here. I have seen Ukrainian nationals come to Seattle and see that in a grocery store and laugh because they buy it in the 2-kilo bags like it's flour, and they bake with it like it's flour. It's a very, very common ingredient. It's used in lots of things, and they will grind that up, mix it with a couple anhydride solvents, and inject that. Right? So the needle exchanges in Seattle are giving out 5 milligram syringes. In Ukraine, they're giving out 20 milligram syringes, and they're muscling that. It's really, really intense stuff. So there's a lot of unique things to know about that. The problem being recognized, this is a billboard that went up actually right outside of my apartment in Kiev. It says, the road to health. And I know this area is kind of hard to see. That's just my poor photography. But you have someone who is drinking, someone who is smoking, someone who is actively shooting up, and various other tawdry things happening elsewhere in the scene. And the idea is there is a way to exit all of this and go into the bright and shiny future where everyone is socially healthy and playing soccer or watching the Shakhtar game or something like that. The way that this was described to me by one of the patients that I talked to, she said, quote, there are some people who like drinking. They like that feeling. I don't. I never enjoyed the feeling of being drunk. I did other things. But the purpose of all of it is just to relax a little bit, But unfortunately, it wasn't that kind of relaxation. It alters your perception of reality. It makes everything fluffy around the edges. And you have these moments where you realize that you're tired of it. You're tired of using. You're tired of going out hunting for drugs, but you do it the same. You hunt, you buy, you cook, you shoot it up. You even do it when you have no veins left. And you're still sitting there for 2-3 hours looking for a place where the needle will hit. So people talk about being stuck in a place and wanting to get out of it, but having no way to exit it. The professional help that is sought tends to be this. So this is what a patient's daily dose of methadone looks like. This comes from a clinic in Western Ukraine. You can see that every person takes a different amount. So some people will take 150 milligrams, some people will take 10 milligrams. It really, really varies. But they will sit there and literally 20, 20, 20, 10, 10. So this person is actually taking 80 or 90, maybe there were 15. They just kind of add them up. They grind them up, and you have to drink them in front of a nurse. And it's heavily, heavily regulated. They have someone monitoring every single day what you take. But the professional help is seen in 2 different kind of ways. The doctors are seeing this as a sort of spiritual intervention with a technological tool. One of the doctors told me, if someone is seeking rehabilitation with a psychologist, their success will depend upon their personal motivation. They must want to change. The psychologist cannot do all of the work, but the addict can't get better without the help of the psychologist. See? So sometimes a patient is motivated inside and just needs to find help. Other times a psychologist must be skilled at generating interest, at building their desire, at lighting a fire in them to change their ways. So this is about personhood, this is about wanting to be socially integrated in a very clear and demonstrable way. Whereas patients talked about the help that they were seeking as largely logistical. And this is a quote from one of the patients I interviewed when I asked her, why did you start this program to begin with? Because it seems to kind of suck to have to come to this clinic every single day of your life. And she said, well, I had a baby. I can't tell you if I'm a good mom or a bad mom, but I try and I do this in order to spend time with her. And this is after a very long conversation about how much time and energy and activity that she was very morally unsure about to try to find drugs every single day. She said, nearly all of my time, not counting the 2 hours that I spend coming here to the clinic every day, I spend with her. I joined the program so that I could be a mom to her. Right? Which is a very, very logistical kind of way of thinking about what's going on. In the end, the question of what problem is solved is also very different. And this is a billboard that was also up by my apartment. It's advertising a locally made beer. There's a lot of local beer in Ukraine. And the slogan on the side says, we should see each other more often. And it's a really interesting window into not only how consumption of alcohol, and this extends into narcotics, because a lot of people, the same way that some people see alcohol and marijuana as a sort of similar sort of social thing, people will see alcohol and injection, shirka, and homemade drugs in Ukraine as a social thing to do. It's a very male-dominated space, it's a very, very social space, and it's a space that people are called into if they want to be socially integrated and network. So in this problematic sphere where we're trying to control people's consumption of addictive substances, the doctors would tell me this. One said, quote, it's important to understand that there are 3 kinds of addicts. First, there are those who used street drugs, past tense, but managed to fully substitute those street drugs with methadone. They slowly lowered their dose and eventually they quit. And that's sort of the ideal treatment trajectory no matter what medical literature you're looking at. But they continued. Remember, even after they quit, they are still addicts because there's no such thing as a former addict. But second, there are those who don't even think about quitting. They like to keep their methadone regimen at the maximum dose, maybe 150 milligrams, and rather than working to slowly decrease it, they'll just sit there. They might want to quit, but they're too afraid. They're afraid that they'll return to narcotics on the street and completely relapse. And then the last group is those who never ever think about quitting ever in their life. They never plan on quitting street drugs either. They use both at the same time, and they continue to use what they want, when they want, the whole time that they're on methadone. And I met plenty of people that fall into each of these categories. So to the doctors, the way in which people achieve success in this treatment program is through actually controlling what they're doing and moving off of it, which deviates very, very significantly from the idea of the harm reduction approach. Whereas the same woman who talked to me about her daughter earlier said, do I like this program? Do I appreciate being on OST? No. At the beginning, when I first came here, I thought it would solve all of my problems. Like I didn't have to hunt for money, I didn't have to find drugs on the street, I just came here, I took my pills, I went about my business. Sounds great. But after a while, I can't go anywhere, not on weekends, not to visit anyone. It doesn't matter where, I can't go. Because every morning, New Year's Day, January 1st, Christmas, everyone is asleep, and I, like a fool, forgive me, but like a goddamn fool, I get up and come here. So at the beginning, it's nice, but it's this vicious circle. I can't quit. I can't go without the methadone. Psychologically, it's very hard. So there's this fundamental disjunct between how patients are understanding success and how the doctors are understanding success. Finally, self-help, wrong computer, is another interesting thing that happened. And this is a sort of very simple archaeology I did of a park that's near one of the clinics that passes out OST. Surrounding all of this stuff is potato chip bags, vodka bottles, cigarette packets. So this is all the paraphernalia of people hanging out in the park in the middle of the night, doing what people who hang out in the park in the middle of the night do, right? So there's plenty of like liquid Demerol that you can get from the pharmacy, codeine tablets, lots of syringes lying around with a significant amount of blood in the reservoir, things of that nature. And I met plenty of people who insisted to me that the methadone that they were taking was kind of helping them, but not really helping them, that they would still have relapse symptoms or their withdrawal at night. And so this entire system is involved, or sort of encapsulated within a greater system of self-care, of seeing methadone as simply one of many, many options for managing yourself chemically and biologically. So here's my last quote from someone who I talked to about what he does on top of his methadone. He said, yes, it's better to live your life without methadone, But what's there to do about it? Of course, it's a switch to something better than the narcotics that are found on the streets. They're more like, they're dirty. From a medical perspective, they're dirty drugs. So you come here, hung up on this muddy swamp water that we inject, and you look me in the eyes and you said, this is not American heroin. These are Ukrainian opiates. We have chemia. We make it ourselves. I can make it with poppy seeds. I mix it with 2 other components, an anhydride and a solvent, and I make it myself. In America, you don't do this. But we're old, experienced addicts, and we do. Even the young folks don't know how to do it, but I've already been doing this for a long time. I've been making it since 1987. So it's interesting to think about what sort of role methadone could have in people's lives when they see it as one of a spectrum of options, right? So if you want to go out to dinner tonight and you think about the Ave, well, there's Mexican, there's falafel, there's ramen. Some things will leave you more hungry, some things will leave you more filled, whatever, and these are all choices that you make with various pros and cons. And methadone is not seen as a medicine for addiction. It's seen as one of the multiple choices that you can make. The pros are that it's free, that it's regulated, that it's very, very reliable, and the cons are that you're chained to this clinic and people are making decisions about whether or not to interact with it based on that. The very last thing that I want to mention is that there was a revolution that happened in Ukraine while I was there. I'm choosing not to talk about it here. I do want to acknowledge that it did happen. And I want to acknowledge it because there was this very, very interesting moment where I, very surprising to me, received a lot of pushback regarding the work that I was doing documenting this. So there was a point where I stopped interviewing addicts and I started full-time documenting the revolution that happened. To the point where certain people who I will refrain from naming actually at one point went so far as to request written confirmation that I would not go anywhere near this because it had nothing to do with my research on drug addiction. And I wanted to say this publicly here with all the students here to point out that that kind of stuff does happen, and to encourage you to recognize the breadth of information that informs the research that you do. I'm highly confident in my ability to justify how the work that I did relates to the work that I do, so to speak, right? I find it all very compelling and connected. But this is one way in which that was brought home to me very recently. This is a tweet that was sent out a couple of days ago, and I found it through some of my Ukrainian connections on Facebook. If you are not fully aware, there are people's militias that are trying to break apart certain parts of southeastern Ukraine. They're holding these fake referendums, and it's a giant cluster. But this is what it says. It says, this was a commentary from someone who's supporting the Kiev government. Said the drug tanks and the narco dispensaries, or drug treatment centers of Donetsk Oblast, have called the members of the People's Militia back to their permanent posts. Right? This is a very, very sarcastic thing, and it is basically casting everyone who has a separatist ideal as fundamentally drug addicted and in treatment. Right? And so much of what has been said about personhood and citizenship and building a nation has to do, it's hinging on a discourse that grotesquely marginalizes people living with addiction. And I find that terribly relevant. So everything that happens continues to tie into all of these things. That's like that. Did I use